Thanks so much for having me. I'm really honored to be part of this esteemed group. So, a little bit of background relative to the background that was given. Back in June of the pandemic, I went to this new barber shop in my old neighborhood, an underserved area, primarily Black. I'm the only person who walks in there wearing a mask. I start freaking out, about to leave there, and I said, well, I think I need to stop and actually engage people and talk to them about my concerns about masks or vaccines or whatever. There weren't vaccines then, to actually get the word out. So I wrote this article about it for our state medical journal. But anyway, you could read that later. So then, right after that, I started working as an investigator on a vaccine trial locally. And, importantly, we didn't want this trial just to be all, white, affluent people, and wanted to engage communities of color. So I ended up being out there in the news a lot, talking about this trial and talking about research ethics and talking about the ways in which we protect people from harm when we do research. And so then there was more and more things, I was telling these stories about Tuskegee and actually how that led to the National Research Act. And anyway, so a lot of issues of health communication and hesitancy came up for me. And that's really all I'm trying to really get at by telling this story. But, I was out there publicly showing myself getting vaccines, being part of a bunch of Black doctors, which, by the way, Black doctors are pretty rare. So, to increase trust in the community, being out there showing your face, being a presence can make a big deal. And even if you're not Black, I mean, just anybody showing up in the community makes the biggest difference. And so that's one takeaway I'm going to keep saying over and over throughout this talk. Show up, be present, listen to what people have to say. They'll take that very seriously, that you hear their concerns. So we held this town hall on Facebook and streamed it from the barbershop, and we had people who were for vaccines and against vaccines and in between, and just had a nice open discussion and dialogue about it. And man, you'd be surprised, the people with misinformation came out hard. I don't know if you see that guy holding the pieces of paper there, but he had stuff printed. He was ready to go. I wasn't ready to address all of that, but the point was we were able to have a very open conversation, because in this case we were somewhere comfortable in the Black community, the barbershop, but also came in with the perception that we wanted to be respectful. And as mentioned, there was this National Shots of the Shop initiative, and my barber, who had been working with me on a lot of this stuff, said, yeah, let's make a lot out of this. And so we set up a longitudinal vaccine clinic at the barber shop in this underserved area to really improve access to vaccines. And we did this for just about a year straight. We have not published the data on this yet, mostly because I'm still busy. Oh, there's interference on the audio. I'm sorry about that. Let me see if I can improve that. We have not published that data yet. Thank you. We have not published that data yet, simply because we've been very busy, but suffice it to say that we gave over 1,000 doses of vaccine in the community over a year-long clinic. And the whole reason for doing this longitudinally is the fact that if you're trying to overcome the barriers that people are facing, I would go and volunteer at these vaccine clinics. You have the YMCA, gymnasium, and there's 100 people and 100 people volunteering rather, and a bunch of booths where people can get HIV testing and COVID testing and COVID vaccines, whatever. But you wouldn't get a large turnout, maybe 50 or 100 people for that whole day, which I'm not knocking. I mean, it's good to get anybody. But the challenge was, for these same day events, I don't think you were really getting the people who were most hesitant, or even a little hesitant. So let's say I'm still deliberating about getting a vaccine, and I walk by and I see this event and I say, oh, cool. You know what, maybe I'm not ready. I'll come back next time. Oops, this was a one-time thing. There is no next time. And then you start ignoring the barriers that get people not to come in. People don't have access to childcare. People don't have transportation. People are worried they're not going to be able to, take a day off if they have to miss work, if they have some adverse effect, whatever, you name it. And so the whole point was doing this longitudinally every Friday, every Saturday for a year straight. And by the way, I'm happy to have my Saturdays back, but I'm sad that this doesn't exist anymore. Was to try to reduce those barriers and to have a presence and to increase trust. And so the other issue you're going to be talking about is trust a lot. And so actually, my barber and I were highlighted in this documentary made on Twin Cities Public Television, which is our local PBS, talking, and it wasn't just about us, but about a lot of different clinicians who were out in the community trying to address vaccine hesitancy. And so I really strongly advise you watch this. It won a lot of awards. It's interesting, talks a lot about it. And even ACOM was nice enough to feature me after I don't know, bizarrely posted this picture of a Pfizer vaccine, and it got like 10,000 likes on Twitter for whatever reason. But anyway, they liked it and featured a story about me. So you could read that back in ACOM Quarterly too. But we also have to partner with the government. So this is me with Governor Tim Walz, who is the reelected governor of Minnesota. Woo! But to talk about getting people vaccines, and this was at a local community college where they had concerns about uptake there as well. So let's take a pause there. We're done talking about me, but now let's talk about vaccine hesitancy. Well, look, if you go all the way back to the history of time, vaccine hesitancy has existed. So let's just even start with smallpox, which, by the way, you inoculated people with a type of cowpox that wasn't infectious to humans. But people say, wait. So you want to inject me with cowpox to prevent me from getting smallpox? Well, that doesn't sound right. And so obviously that was weird. But now in the US, we've seen these issues following the Wakefield study in the 90s, where vaccine hesitancy, even amongst more commonly accepted vaccines like MMR, has been prevalent. You see some of that getting better in this graph over here. This point I make about post-infectious disease consequences, which I showed President Roosevelt, who was in a wheelchair because of polio. Well, we are spoiled that we don't see any of that anymore. I've never seen anybody in my life in a wheelchair because of polio. I'm 40 years old. But nowadays, even, I had chicken pox as a kid. I may have shingles in the future. Well, kids who, are younger than me aren't going to get chicken pox because that vaccine came out when I was like 16 or 17. And so, as we do a good job of vaccinating things, we lose seeing the consequences. So then people say, well, wait, why do we need a vaccine in the first place? And so then in communities of color, as an example, there's other issues of trust in other communities. People talk a lot about the Tuskegee syphilis study where, people were not treated for syphilis even after the treatment for syphilis, penicillin, came out. And this was a big deal, and it went on for 4 decades. And the good news, this is what people don't talk about, is it led to the National Research Act and the establishment of IRBs and the Belmont principles and all that stuff that we enjoy and love now. And, unless you're doing back alley research, thankfully people are protected. But, in, for example, the Black community, which I'm speaking to, knowing that, people talk a lot about Henrietta Lacks and the HeLa cells. People talk a lot about Marion Sims, the father of modern OBGYN, who did, a lot of advanced vesicovaginal fistula surgeries on slaves without their consent. And so, that stuff is part of the historical narrative that Black people talk about when they're growing up. And we know systemic racism is a big thing, but, even forget racism. What about classism? What about affluencism? Poor people come in, people who are, houseless, all these things. And, there's bias in our systems against that. And then now, of course, being from Minneapolis, I got to mention law enforcement violence, yet being another way in which people of color, for example, but again, certainly other communities who are disenfranchised see, gee, these systems may not only not be looking out for my best interests, they may be actively harming me. Okay, great. Well, changing trains on that subject a little bit. So vaccine hesitancy was addressed pretty broadly in 2014 by the World Health Organization. Put together this SAGE working group that talked about vaccine hesitancy, and they came up with this 3C model: complacency, confidence, convenience, all of which is to say, these are domains in which people might be considering hesitancy, like, well, I'm complacent, I may not need it. Or confidence, well, I don't know if this is going to work. Or convenience, I don't know, it's not easy for me to get this. But they also pointed out, when you're talking about hesitancy, you have to think about people are on a continuum. There's some people who are like, hey, yeah, I'll just give me whatever vaccines you got, I'll take them. I'm in that category mostly. But whereas some people are like, no, I don't want any vaccines whatsoever. And then there are some people who are like, well, I'll take this one, but not that one. I think COVID actually hit that a lot more than average, because you'd see a lot of people who were actually fine with vaccines, but who were then like, man, I don't know about this COVID vaccine, it's too new. There are the people who want to delay vaccines, which is like a whole nother story. And then some people who take some and leave some, or do some doses and not other doses. It gets kind of wild when you go down the rabbit hole. That's why this is a tough talk, because vaccine hesitancy is such a big topic. Oh my gosh. And so looking deeper at what Sage was talking about, they kind of broke it down into these 3 sort of broader spheres in which people can be influenced. You have your contextual influences, things that are going on out in greater society. What's your religion? What's your culture? What are influential leaders saying? What's said in the media? What do people think about the companies who are making this stuff? You have your individual beliefs, or your family's beliefs, or your community's beliefs about vaccination, or even just needles or the pain of getting a vaccine. You have people's awareness about what these do or don't do. You have people's trust in health systems. And then again, what the social norms are around getting immunized anyway. And then you look at individual vaccines, and this is where it really became a big deal with COVID, for example, or even influenza. There's this issue of risk or benefit. You hear people talk all the time, even before COVID, about, well, gee, the influenza vaccine doesn't really do anything. It's not that effective. I don't want to get that. That's the same story you hear about COVID, by the way. So then you look at the mode of the administration and the other ways in which very specific aspects of a vaccine can play a role. So, you'll see people who are, for example, hesitant about getting a needle in the arm, but they're like, oh, I would love to take a thing in the nose. My daughter's in that category as a 10-year-old. So anyway, a lot to talk about in terms of what influences affect you thinking both internally, externally about your choice to get a vaccine. And so expanding on the work from the SAGE working group, this is from probably, I think, one of the more famous papers about vaccine hesitancy. And they talk about this issue of the 3C model, the confidence, convenience, complacency. We moved on from there over time to a 4C model, where then you added this calculation, which is how much are people engaged in like researching and thinking about this and looking into this. And so that's, something that became more interesting. There was this shift to this 5A model, this so-called taxonomy, where again, they're kind of similar things. They just go from A's to C's and C, whatever, it don't matter. But they talked about acceptance, how much individuals will accept or question or refuse the vaccine versus access to get it or affordability of getting it. That plays into the convenience from the C model. How aware people are for the need of getting the vaccine or how available it may be. And that, again, plays into complacency. Activation, that is to say, how much do people feel like they are motivated to get it? That goes back to calculation. And then when we move to this new 5C model, which extended the 3 and 4C model, we have this additional one of collective responsibility. And instead of convenience, we now have constraints, which is just looking at it from a different perspective, like rather than how easy is it for you to get it, what are the barriers to you getting it? But the collective responsibility is an important one too, because with respect to vaccines, you have to ask yourselves from a public health perspective, how does me getting this impact everybody else? Important. Okay. Thinking about, your sort of good old social theories, here's a theory of planned behavior. And so the theory of planned behavior really talks about the function of a behavioral intention for somebody to pursue a certain behavior. And so somebody's intention is a function of their individual attitude, their perceived behavioral control, and what the subjective norms are therein. And so this was in the context of a paper talking about influenza vaccination. But again, you look at somebody's individual determinants psychologically as they pertain to their sociodemographic and physical determinants, and all of that will extend into their intention to get vaccinated, where psychologically people sort of, what's the right word, encompass or embody, or what's the right word, they take in for themselves the subjective norms and make that, that sort of builds on their own psychological determinants to affect how they feel. But a big point of this is, and this comes up in all theories of hesitancy, this perceived behavioral control. How much control do I have? How much autonomy do I have to make this decision? And that is a big point in motivation and action. And that's something I think is worth taking away from this too. Here we go. So here's just another look at that 5C model, again, where your confidence is how much you trust maybe the vaccines or how it's delivered or the people recommending them. And by the way, these have all been major issues. This confidence issue is probably one of the biggest in COVID-19. The convenience or constraints, right now, I would say this is not an issue. Everyone can get a COVID vaccine if they want. Everyone can get a flu vaccine if they want. But unfortunately, people may have issues in confidence. The complacency, again, how risky is the disease? Right now, that's a big problem for COVID. Maybe not as much for influenza. People think influenza is dangerous, but nowadays people are like, oh, COVID's mild. If I get it, I'll just have a runny nose. I'll feel fine. So this is not a priority for me. And the calculation, well, this part actually is high, I think, in terms of people's interest in seeking information. And we have such great information out there, but they also have a lot of bad information out there. So even though people are interested in making these calculations, they may not be making the right calculations. And then this collective response issue, oh my goodness, we could probably talk about this all day, and I'm not going to go there that much, but just to say that that's a consideration. And a lot of people are really mad right now because the spirit of public health is to protect the most people most vulnerable, but yet it seems like nobody's really that worried about that as it pertains to COVID. And so there are a lot of people who are immunocompromised or who may not be fully abled, and this is a big concern for them, that getting COVID will make them very sick and have a lot of problems. In clinicians, we see a lot of hesitancy following the same exact sort of domains that have been discussed. You have your contextual influences about your own personal beliefs and the groups that affect you, also the communications you're seeing, and importantly, historical influences as mentioned. But then if you look at, at the individual level from a social perspective, again, is immunization what's a social norm? And that's where I think workplace can play a big role, because what is expected, whether it's a healthcare setting or otherwise, about what's expected as far as behavior within that environment, what people believe or what their motivation around health and everything is, what are the risk benefits again, and then again going back to vaccine specific issues, and that's where incentives come in as a big deal. And so people will talk a lot about the sort of carrot versus stick approach, to vaccination or other health interventions. And so incentives are really more on the carrot side. Geographic access again is reducing the barriers, and then providing people with appropriate training and education again is reducing a barrier, at least an informational barrier. So again, we have to also, I think, be clear with people about what effectiveness really means, and I could probably talk about that all day. But just for reference, when I talk to people about efficacy, I say, look, vaccines are designed to do three things, and by the way, they do them all in the same way. But number one, they're supposed to help prevent you getting disease. They're not always going to prevent you getting disease. They're supposed to help prevent you spread a disease, not always going to prevent spreading disease. And lastly, and probably most importantly, help prevent you from getting severe disease, hospitalization, death, whatever. All of that's done by, in theory, like for example, for COVID, reducing the viral load of the disease, because the vaccine will help your immune system fight it. So when people talk about effectiveness, you gotta say, well, what does do vaccines work? What does that mean? Well, work for what and to what degree? This binary, and I could have talked about this whole conversation. This binary black and white of things are good or bad is one part of the conversation that we've been failing with as well. So one thing that mediates trust for people is, again, do they trust in a product, whatever it is? Do they trust a specific mRNA vaccine? Do they trust in the clinicians who are delivering it? And do they trust in the systems that actually are recommending it or advising you to get it? And so some of this is affected by historic trust and distrust. Some of this is affected by things externally. And then there's this generalized pre-existing trust or distrust for a variety of number of reasons. So we see, for example, in COVID-19, vaccine acceptance was affected by trust in various sources. And I thought this was just an interesting graph where the dark is low, the sort of semi-dark is some, and the light is high. But you see the highest trust in sources like YouTube, Facebook, Instagram, Twitter, TikTok to some degree. And when you go to things like, actual TV, well, okay, fine. And radio, maybe not so much. And that's interesting because, I think this just is telling about where people are seeking information. More is going to come up on this later, I assure you. So then just again, looking at nurses in terms of this 5C model of the, a vaccine uptake, again, you see that for them, it was confidence that played a big role for the COVID vaccine. Whereas collective responsibility came in second, and constraints and calculation, like having to think about the risks and benefits, that wasn't that big a deal. And some of this played into work stress that they had around not having enough PPE, or their attitudes towards how much control they had going on in the hospital. So again, this is just showing a little bit of that balance of internal, external factors, and it's never really going to be the same for every individual. And that's yet another takeaway, which is there's not one big thing that affects every person individually. Okay, so now going back to what I was talking about with respect to race, and I just have to talk about this as a Black doctor and as this being a big mediator for hesitancy, but not the only one. But the big thing, and this is true for all such social determinants, but all these social determinants are mutually reinforcing. So, it might be a worse health risk factor to be Black. It's a worse health risk factor to be poor. It's a worse health risk factor to be homeless. But having all those things together is synergistic negatively. So, something to consider. And we saw this reflected for life expectancy for Black people even through 2009, but this looks the same today, where again, there are these gaps between white people and Black people as it pertains to life expectancy. And even though everyone's life expectancy has improved, those gaps really just have not narrowed, and that's concerning. You see the same thing reflected in terms of chronic disease. And so again, even across all age groups, Black people experience worse hypertension, diabetes, and cardiovascular disease. No surprise. And it turns out Black people, for example, and again, this would be true for every social determinant, just to varying degrees, are more likely to die from all causes at all ages. And this was published, not this particular finding, but this type of finding was also published in like JAMA in January 2021, where it showed a relative risk of like 1.27 just for being Black for death from all causes. Scary, but true. So the point is, systemic racism is its own social determinant of health. If you want to go deeper down that rabbit hole, colorism is its own social determinant of health. Being Black or being dark-skinned, regardless of your race or ethnicity, actually is a bad thing. And it turns out this all impacts things historical, like slavery and the GI Bill and Jim Crow law and redlining, and all of that actually is relevant to other social determinants as well. I'm just using racism as an example here. And we know that clinicians have bias as it pertains to race or ethnicity or socioeconomic status, etc. And the big thing here I'm just showing in this diagram is, we may have some biases and people may have some dissatisfaction or mistrust after a clinic visit. And in the long term, they may not adhere to or utilize healthcare as much. And what will change that is our communication with people during their visit. And so ultimately, we have to do things to try to improve our bias as it pertains to race. We need to look at anti-racism stuff, but overall, empathy and reducing bias is a big deal for us that we need to keep working on. Now, the bigger point I was trying to make using race as an example is that we know social determinants are bigger impactors of the outcomes in healthcare than what we do in the clinic. This diagram suggests it's 20% of what we do in clinic, and the other 80% is everything outside of the clinic. Some things say it's as high as 50-50, but more like 80-20 or 90-10. So again, we have to think about what's going on outside of the clinic as it pertains to our patients, and consequently, in this case, their considerations of whether or not to be vaccinated, unvaccinated, etc. Oh, I didn't see some questions. I'll have to look at those in a minute. But we'll come back to them. All right. Now, if you look at research on workplace vaccine hesitancy, and this is just one set of search terms, you could do a bunch of things. But the point being, it's overall quite limited. And so there's a lot of stuff to go there. And looking at the questions in there, so Dr. Pereira, who I know, one of our former residents, we can talk about the 5 C's, and I got some tangible stuff at the end here for sure. Somebody else asked the question, isn't some of the vaccine hesitancy related to the fact that new vaccine utilized technology was under emergency use, and that's a legitimate concern? Vaccine hesitancy been around before COVID. Is vaccine hesitancy limited to COVID or communities of color? To answer that question, vaccine hesitancy is not limited to COVID. It just was worse, and there were some focal features around COVID, as you mentioned, like the vaccines being new. And nowadays, like COVID's not that big a deal. Communities of color, some of the issues of hesitancies were unique and worse, such as the Tuskegee syphilis experiment, but vaccine hesitancy has existed more broadly. Somebody else now says, politics influenced COVID. VP Harris and Governor Cuomo's statements on the Trump vaccine, their doubts about it, created hesitancy, mistrust, and undermined this, especially in communities of color. Yes, this is true. So I didn't go here that much in this talk, but as healthcare professionals and really as a society, we did a bad job supporting the public health layout of what was going on. There was a lot of unknowns. It was a shifting landscape. We were changing information fast, which we needed to, but unfortunately, we didn't tell people that it was a shifting landscape and that we were doing the best we could with uncertain information. I think it was really, people took it like this is hard and fast known information, and it's not. And the fact that people thought we were saying that was a bad thing too. And now we keep going back and forth about the severity of this, and that's yet another issue. So I don't know, that's a whole talk in and of itself. Okay. So we know in the workplace setting, as I'm saying, forget vaccines, I'm just talking about straight up occupational injuries, mistrust exists between employees and employers. And so this study I thought was cool because it talked about occupational injuries as people reported them versus their job reporting them. And the big point I'm trying to make here, there was greater discrepancies between a person reporting it and their job not reporting it, or a job reporting and a person not reporting it, between in communities of color. So I mean, no surprise there. Dr. Benning asks, how do you recommend clinicians start the conversation to address hesitancy? That's the tangible stuff at the end, my friends. You're waiting for it. And so this issue of mistrust as a function of peripheral trauma, I've talked about a little bit so far. Just to bring up another couple of points, again, outside of the Black community, you saw with the AIDS epidemic, there was a lot of infectious disease stigmatization in, the men having sex with men communities, and we're seeing this monkeypox. As far as COVID-19 was concerned, people talk about the China virus. And then we see with, underserved and underrepresented communities, people talk about people aren't believing when patients come in with pain, or they're saying, oh, this person's drug seeking or malingering, or this person's a difficult patient. We got to stop that language. And, look, there are systems affecting our patients more than patients' own ability to like not be interested in what we're doing. Now, the issue we know exists is this issue of information overload. The WHO has called this an infodemic. We have too much information. They say during disease outbreak, but we know this existed before. There's been more and more information over the past several decades. We have these increasing echo chambers, people being able to find sources that support whatever it is they want to believe. And ultimately, people have difficulty accessing accurate sources, or at least knowing what those sources are. So I always joke around and say, well, like you could search on Google for information about COVID-19. And actually, this is a joke because my Google wouldn't look like this. This is actually going to vary depending on what you normally search for. And so, unfortunately, our search engines are perpetuating this echo chamber effect because they're going to keep showing you results that reflect what you've already been seeking. Dun, dun, dun. It's true. And so we know employees are getting information from lots of different sources, whether it's this information we give them formally or informally at the job or from their colleagues, but out in the community, probably even more commonly from their union or from the news or from social media or from family and friends. So all this to thinking about how do we use the workplace as a place to intervene on this? More to come there. So just in terms of this echo chamber effect, I just wanted to point out that academically, people call this cognitive conservatism. That is, it's a natural tendency for us to resist changing what our view of our own self-concept is, but also looking for information sources that reinforce that self-concept. I want to believe that what I believe is right, and I need support for that. Yeah, scary, but true. And so we see in certain groups, this happens more commonly, again, whether it's communities of color or underserved communities, or people who generally are not in the majority, where again, even just by general mistrust, you may reject true information. I would say epidemiologically, that's a type 2 error, a false negative, versus, you may accept information that's false because you trust the source. It's not a source that you think is against your best interest. It's your friend Joe who's going through the same thing as you. And so I want to believe him. Now, we see in a lot of these groups this issue of, quote, conspiracy theories, which, again, this is people trying to find different ways to describe why they're experiencing this chronic social devaluation. Why does my life suck so much worse than everybody else's? And, trying to look for these alternate explanations can do that. The problem is, as people in power, if we say, oh, yeah, that's a conspiracy theory, we're continuing that same perspective of devaluation. So don't do that. Okay. We're going to change trains for a second to talk about some work we did looking at vaccine hesitancy in firefighters. And so we did a survey in firefighters around the state of Minnesota because we know firefighters have increased exposure to COVID-19. And there's been all these news reports saying that firefighters and other first responders have a lot of vaccine hesitancy. And in part, this is due to them having mandates. So maybe just being against it. And then there's, all these general reasons that people don't want COVID-19 vaccines. I'm going to go fast through this because I really don't want to dig into these numbers too bad. But this is just an example of a story on NPR, firefighters, in this case, it was in LA, didn't want to get COVID vaccines. And so we were looking at, well, one, how much are firefighters actually vaccinated and how prevalent is COVID in them? And what factors might predict if they were to get a vaccine? And do they, in fact, intend to get vaccines? And so this is the health belief model is, yes, Amir Wolf, you're correct. The term cognitive conservatism, I don't know if it's biased as much as it's unfortunately affected by the colloquial use of the word conservatism, which means something else politically. I was just saying an academic, esoteric term, cognitive conservatism, is this issue of resisting change in your self-concept. And so you're right. People will be thrown off by the word conservatism, but I was just telling you what the technical term is. Anyway, so looking at the health belief model here, and I know it's funny I can respond to these questions so fast, but this is what I do. So looking at this health belief model here, you have the individual modifying factors, what is your age, race, demographics? What are your individual beliefs? This is the part of the health belief model you guys are used to seeing, your susceptibility, your severity, what's the benefits versus the barriers. And then, what are the cues to action for people? Who do they trust for information? Remember, trust, we talked about that. What's your availability, or what are the barriers to you getting vaccinated? And what are the social norms? What are your friends, colleagues, and people around you doing? And so we did a 6-week survey where essentially we had a lot of questions in there. And the incentive was a $100 Amazon gift card was drawn for 10 people a week over the 6-week period. And people had to provide their email address for us to do that. So that was one way to find out if people were concerned about privacy, which was a concern. And we also wanted people to give us their information to link to the Minnesota Department of Health to find out, did they in fact have COVID or a vaccine? Not as many people did that, about 10%. And so we just asked simple stuff, how long have you worked in the fire service? What was your rank? What's your race, ethnicity, level of education? Have you ever had COVID? Are you vaccinated? Are you going to get vaccinated? What's the setting in which you work at? And do you have a mandate? Do you know people who died from COVID? Have you refused other vaccines in the past? Great. And we saw, we asked people about their attitudes, how much do you think your risk is of getting infected or having complications? How effective is the vaccine? What concerns do you have about it? Do you feel like it's easy to make a decision and that you're autonomous to make such a decision? What are other people doing? And again, similarly, what are the sources you would use? Is it your family, your colleagues, your friends, media, social media, public health departments, doctors, etc.? And so we got about 1,371 responses. Turns out about nearly 300 of these were fake. That's a whole nother story. But this was basically an open internet survey because we wanted people to be able to do this anonymously. And so that led to some fake data. But overall, we got about 974 responses in total and about 74% vaccinated, which basically just says that firefighters as a whole, certainly for the population that was studied, are vaccinated about the same as the population, which is actually not good considering their exposure is so much higher. And most of the departments that were included in the survey didn't have vaccine mandates. And the people who were not vaccinated very much did not plan to get vaccinated in the future. And the people who were not boosted very much did not plan to get boosted in the future. I'm going to skip through some numbers, but just show you, just generally like what it looked like. And so we, collected data on, simple demographic stuff and how this portended being vaccinated or not fully vaccinated. I'm not showing the data on boosted versus not boosted because that looked a lot like people vaccinated versus not vaccinated. I do have an idea of how many were EMTs and paramedics. I don't have it in this data, mostly just because I wasn't planning on going that deep in this. But that was one variable we looked at, whether EMT training and the degree of EMS service provided by a department portended people's likely to get vaccinated. It did a little bit. And interestingly, here you can see race and ethnicity actually had no effect, which is actually surprising a little bit to me. And so now here's where it gets really interesting. If you're looking at people's perceived susceptibility and autonomy, etc., the long and the short here is you basically see that there are statistical differences between these two groups. And generally speaking, for the positive things, that is, the vaccine works and it's good, it was better in the fully vaccinated group. For the negative aspects, how susceptible, what are the likelihood for side effects, or what are the barriers and things, you see that higher in the not fully vaccinated group. And that's just a quick takeaway. But the point was, these are very different groups, and the perceptions that people had towards vaccination were very different. Similarly, what people's information sources were totally different between fully vaccinated and vaccinated groups. But the bigger point overall is, if 4 is, representing people really trusted people, and 3 is like they kind of trusted people, the highest numbers in this whole table are like 2.5. I don't want you to read these numbers. I'm just making the points, and I'll give you the highlights in a second. So what we saw with the attitudes was there was completely significant differences between those who were fully vaccinated, not fully vaccinated versus or boosted. Firefighters generally did not seem to think that COVID-19 infection was likely, though that concern was greater in the vaccinated, but they didn't think it was that likely. Firefighters did seem to think that COVID-19 was a severe disease. They did feel like they could make a decision about vaccine and that they're free to choose about the vaccine. And the fully vaccinated, not fully vaccinated groups really differed on the benefits versus the barriers. And you saw the social norms for people who were vaccinated. It was common that they knew people who were vaccinated, and people who weren't vaccinated, it was common they knew people who weren't vaccinated. Now, really interestingly, with respect to trust, we saw overall there was really low levels. Less than 2.5, which is right in the middle of that scale, almost for everything. And the good news is that highest point was for actually scientific literature, scientists, public health professionals, and somebody's own doctor. But again, the differences were significant between the two groups. Turns out the fully vaccinated people pretty much had higher trust for everybody, with the exception of social media or the internet or community religious leaders. That's weird, but interesting. And both groups had about equal and low trust for fire department leaders and state fire organizations. So that's super scary to me. One other thing I think is worth mentioning, and this jumped out at us as a very interesting finding. Overall, looking at this issue of autonomy, both groups had very high autonomy, but it was statistically significant that it was higher in the not fully vaccinated group. And similarly with decision-making ease. Now, this decision-making ease point I think is interesting because it suggests to me, well, everyone found it relatively easy to make a decision. It was easier to make a decision if you were not fully vaccinated. So that makes me think, wait a second. So the people who were not vaccinated found it even easier to make that decision. Well, that goes back a little bit to that issue of cognitive conservatism or sort of cognitive rigidity. It's like, you know what? I don't want this vaccine. I don't care what you tell me. I don't need to think about it. I'm just not going to get it. Maybe the people who were vaccinated took a little more time to think, well, what are the risks and benefits? Do I actually want to do this? Do I not want to do this? This suggests to me, if we think about how to actually get people to consider the issues that might actually affect them, they may be more likely to change their mind versus just saying nope or yes blindly, which is kind of interesting. Okay. Changing trains now to the points everyone asked about. What do we talk to people about? Well, number one, talk to your patients about medical ethics. Now, everyone's going to say, this sounds esoteric and stupid. It's not. I talk to patients about patient autonomy all the time. I say, look, in this exam room, you're the boss. You can choose to do whatever you want. Patient autonomy says so, and I believe in that. Basically, you are your own person to make your choices. I'm just going to give you information. How you want to use that is up to you. You can take everything I say and use it. You can take everything I say and say you don't want any of it. You can take some things and leave some things. We have to let people know that they are empowered to make choices on their own. We cannot tell them what to do, and we don't want to tell them what to do. And I'm tired of people saying, my doctor is mad at me. This means people are not feeling autonomous, and we should not give people that perception. You have to talk to people about the fact that we balance risk and benefit, beneficence and non-maleficence. And lastly, talk to them about the fact that justice is a big deal to us. We know that what happens outside the exam room affects you, and you may not have access to pay for your insulin. So you know what? That's a bad thing, and I want to help you fix that. How do we do that? My point is telling patients that these are the things that we rely on as patients, I actually feel does improve rapport and trust. Okay, so now, most importantly, this is what I made up to talk to patients about. I haven't published it yet, but I'm probably going to. So I'd say, hey, approach your patient with verve. That's the name of the paper. Shoot, why not? So you want to verify what that is, what their concern is. You know, talk to them about that, ask them about it, contextualize a little bit more detail based on that. Ask them some more questions to engage them about what specific aspects of their concerns are, or give them some positive statements about engagement, like, hey, thanks for looking into this. Reassure them that, hey, I actually agree with you on this point, and this is how this actually works in reality. Validate their concerns and make sure they know that you're aware of why that is a problem, and in fact, that may have been a real thing in the past that might not be a thing now, for example. And educate them. Oops, I didn't change the text there, but basically let them know what really concerns you about what they're, how you may affect what they're doing. So we see trust be a big issue. People say, well, I don't trust doctors. So I'd verify that with them. I'd say, well, look, you showed up to this appointment at a doctor. What do you actually want? Engage them and say, okay, fine. If not doctors or me, who do you trust? Reassure them. I'm just trying to do my best job today, right here, right now. And validate and say, yeah, it's kind of similar to motivational interviewing. You're right, but I'm trying to be more specific. Say, look, I know healthcare has not always protected communities of color. In fact, has harmed communities of color, for example, if it's a Black person. I'm just using that as an example. And say, look, I'm not asking you to trust the government. I'm not asking you to trust anybody, doctors. I just want you to trust me right here, right now. People talk about, well, I don't want to be a guinea pig. Hey, look, are you actually worried that we're experimenting on you? Hey, and I thank you for coming in and telling me that this is a worry you have. And, look, going back to patient autonomy, we respect you choosing for your own body. You can say no to anything. So you're not really a guinea pig, because at the end of the day, you can just say, I don't want any of this. You can validate them and tell them, look, I know about Tuskegee. I know about health research. I know about problems in healthcare in the past when we have experimented on people and it's been bad. And just let people know about, well, hey, this is not research. This is standard of care. I know about Tuskegee. That actually led to research protections you've never heard of. So there's ways to educate people to reassure them. People say, I don't trust the government. I just thought this was a funny picture, and I'll take a second to let you look at it while I drink some water. And so, just another picture of Killer Mike. He said, I don't trust the church or the government. Anything church or government tells me, I assume to be a lie or conspiracy until otherwise proven true. But that's true. You hear people talk about that. And so you'd say, well, gee, are you concerned the government's controlling my decisions here? Or like, well, tell me a little bit more of about what you've seen the government do about vaccines that might concern you. Or tell them, hey, as your doctor, your nurse, your social worker, whoever I am, the government does not control what I do here, and they don't. And by the way, I know the government has armed communities like yours before, and sometimes that feels like it's out of our control. Validate that. And by the way, I'm not asking you to trust the government. I ask you to trust me. And by the way, government entities don't prescribe medications. I'm doing that. They just approve them. And I agree with that approval in this particular case for this vaccine, for example. People say, oh, my body can heal itself. I don't want to take a pill. And I'd say, well, okay, well, if you don't want a medication, what do you want? You can reassure people that ultimately we don't want people to take medications either. And so we're doing our best to try to make that our last resort. And really, at the end of the day, our job is to try to help you make better health choices so that you don't need medication or a vaccine or whatever. I mean, vaccines are maybe hard to avoid in that regard. And so then people say, oh, well, I do my own research. I just like this comment. I'll leave it for a second. And this goes back to what I was saying about the search engines helping us. And so again, tell people, look, can I look at some of the stuff you found so we can talk about it? I'm really glad you're interested in looking at that. You know, we want to help you sort through this so you can find everything that's out there. And by the way, do you know how to check your sources? And so lastly, I just want to reemphasize, we know as occupational medicine doctors, the workplace is a great place to intervene on health promotion. That's really the basis of total worker health. And so we can use the workplace as a place to get education out there, to get vaccines out there, to really improve prevention and improve health, both in a work and a non-work related context. And this is the last slide, just another slide of the workplace health model in detail. So that's it. Let's talk. I kept it to 40 minutes exactly. Whew, scary.
Thank you so much, Dr. McKinney. That was a whirlwind. We really appreciate it. I believe you addressed most of the things in the Q&A. The one I'm just not sure about is the question that said, any idea what % of firefighters were also EMTs and paramedics?
Yeah, in that study we did, it was like almost 100%. I think there was like literally one person who maybe wasn't.
Oh, wow. Thank you.
But that should be coming out probably in the next few months. Yeah, I got a question here that somebody asked. They said, what do you think about docs not treating unless vaccinated? I think that is not consistent with the spirit of medical ethics around patient autonomy, evidently. That is to say, you know what, it's patient's choice not to get vaccinated. And consequently, we shouldn't fail to treat people as a function of that. Now, if you want to get into the fantasy world of, well, we don't have enough resources to treat everybody, do I consider whether somebody's been vaccinated or not first? That's a different ethical issue, which I think is beyond the scope of this presentation.
Thank you again. A very valuable presentation with so much information. We really, really appreciate your time.
Thanks so much for having me.